super exciting. I'm at work, by the way. Dr. Bruling's also at work. I'm getting pages and phone calls while we're at work, but we want to take this time out to talk to you about something that is so incredibly important. It is Colorectal Cancer Month. I have some personal questions for Dr. Bruling. So hopefully y'all are going to get a bunch of great information out of this, and we'll just use me as a guinea pig. How about that? So joining me today is Dr. John T. Bruling, gastroenterologist at Pacific Medical Centers. And before we get to the particulars, or I guess before we get to the fun stuff, I have to go through the particulars. As a reminder, the information provided during this event is for informational purposes only. If you have any medical questions, please reach out to your primary care or healthcare professional, okay? Always seek the advice of your primary care provider or qualified health provider with any questions you may have. This is for informational purposes only. All right, now that that stuff's out of the way, one more little housekeeping item. There are a ton of you who are watching this on Facebook and LinkedIn and what's the other one? YouTube. And a lot of times we do these for half an hour, but we're trying to mix it up a little bit. We're gonna, speed things up. It's the TikTokification of everything in our lives now, right? We got to be able to do everything and communicate it to you super fast. So don't forget, if you have questions for Dr. Bruling about Colorectal Cancer Awareness Month, any of the things we're talking about, drop them in the chat wherever you're watching this. We've got people standing by to take your questions, and we will answer those as we get through this, but we're going to move it kind of a little faster than we normally do. And that being said, Dr. Bruling, welcome.
Thank you. Thanks for having me on.
Yeah, of course. And for those folks who haven't met you, just tell us a little, a quick brief thing about you and what you do with Providence.
Sure. So I'm a gastroenterologist. I work at Pacific Medical Center under the Providence umbrella, and I'm mainly in the downtown Seattle location at First Hill at PacMed, but I also, have a clinic down in Renton. I do procedures here in the downtown location as well as going out to Swedish Issaquah. And I have two partners that work with me, Dr. Rex Chang and Dr. Elizabeth Broussard, also PacMed gastroenterologists who go up north for clinic, but we mainly center our procedure in the downtown Seattle location.
Excellent. Very good. So the topic of our little chat here this afternoon is very specifically about Colorectal Cancer Awareness Month. And just, I guess, let's level set. Let's start at the beginning, right? We toss around this word colorectal cancer awareness and people immediately tie that to colonoscopies, but some people just don't even know what we mean when we say colorectal cancer. So what is that?
When we talk about colon cancer, we're specifically talking about a type of colon cancer that's by far the most common. It's called adenocarcinoma of the colon, and that's makes up the vast majority of colon cancers. And that's what we're, talking about, not only screening for, but trying to prevent. And I think we'll get into that a little bit, how we do that.
Sure. Now, screening, right? Whenever we talk about cancer and we hear the word cancer, we think about screening, not only as healthcare providers, but also as, lay folks. There have been some pretty good public health campaigns out there about getting screening, but I know that the ages have changed recently for like that first colonoscopy. So let's talk just a little bit about colonoscopies as a screening tool. And then what age do you recommend those?
Yeah, so you're right. About a year ago, the GI societies changed the age. So it used to be 50 is when we would recommend, and this is for the general population, what we call average risk, but they lowered that last year to 45. And a lot of that is because colon cancer rates, since the 1980s had been going down fairly dramatically until early 2010s, colon cancer rates started going back up again slowly. I don't know if we know exactly why that is, but that's despite, doing screening and all that kind of stuff, things are going back up and younger people as well. So that's why, the age was lowered to 45. So for most people in the community at what we call average risk, we're supposed to start at 45.
And that's for men or women or however anyone identifies, right? So just everyone at 45 at average risk.
That's right. So men, women, any race, it's 45. Now that there are some populations that are higher risk. So those people with a first degree family member with colon cancer, it's usually earlier than that, usually 40 or 10 years before they were diagnosed. And then also if you have inflammatory bowel disease or some other kind of genetic disorder that makes you higher risk, those are kind of the groups that are a little bit different. But otherwise, it's 45 for everyone.
Gotcha. So there might be some folks watching. So when you say first degree family member, is that like my mom and dad? Is that uncles? Is that grandma and grandpa? Is that cousins? Like who counts as first degree? Because I think this is really critically important for a lot of people to understand.
Yeah, I think it's confusing for a lot of people because we get these kind of questions all the time. So first degree is relating to, either your parents, your siblings, or your own children. Everyone else outside of that is what we would call a second degree family member. And in the guidelines don't really pertain to that. They don't count second degree family members as being high risk. So yes, it would have to be, again, parents, siblings, or a child to count as a first degree family member.
Very good. And all right, just to clarify for everybody watching. So if your parents or siblings or your own children, I guess, have had colon cancer or a scare even, or high risk, something like that themselves, we're wanting you to get this colonoscopy specifically earlier at age 40. Now, what if, for instance, this is where I'm going to insert myself a little bit. What if I'm, I just happen to know someone, who's maybe 44 years old, but might have, I don't know, history of hemorrhoids or something like that, like something that's not necessarily, precancerous by, at least according to the research, but you're like, maybe I'm worried. And I had a grandparent who had colorectal cancer. What would you say to that?
Well, so when I talk about, doing a colon cancer screening and the ages we're talking about, I'm mainly talking about, is for preventative care and screening purposes. But there are a lot of times where we would also do what's called a diagnostic colonoscopy. So even if someone's, younger than that, and they have symptoms, whether it's bleeding from down below or weight loss that's unexplained or anemia or diarrhea or something like that, might lead us to do a colonoscopy for other reasons. So that's a little bit different. So in your case, if someone was 44 and they were having rectal bleeding, I think the first step is just to talk to your primary care doctor first, maybe get referred to a gastroenterologist to talk about whether a colonoscopy is appropriate.
Awesome. Now you mentioned some symptoms. We're going to come back to those in a minute, because this is the thing that everyone, right? I'm sure you get these questions 100,000 times. I know I do. Oh my gosh, my poop is green or whatever. Like, I have cancer. I'm going to die. Like, what do I do? Right? We get those questions all the time. But before we go on to that, because we're talking about screening, I think this is really important. I just saw one of these commercials last night. Order this test and take it at home. And if you're of average risk, it's 90-some-odd% predictive for whether your risk of colon cancer. I don't know, whatever. Break those TV commercials down for us, since we have your expertise.
So I think what you're referring to is just kind of breaking down what the screening tests we have available are. So in general, we kind of push two tests for screening because there's a little bit more evidence behind them. One is the colonoscopy, which we'll probably get into a little bit more. But the other is a stool test called a FIT test, where we're testing for microscopic amounts of blood in your stool. Those are the two that are preferred. The FIT test is obviously a little bit easier for patients to go through because it's just a stool test they turn in. It's a little bit cheaper. But the disadvantages of it are it's every year, and it's mainly to detect early cancer rather than prevent it, although it can detect some precancerous lesions. So that's the pros and cons of the FIT testing, whereas the colonoscopy, obviously a lot more to go through because you have to drink a preparation to clean your bowel out. You have to be put to sleep, but it is less frequent, and there is some evidence to show that it's more preventative for colon cancer. So not just screening, but possibly preventative. What you might be referring to is there are other tests. There's the other test called a Cologuard, is commonly referred to, which is a stool test every 3 years that does both blood and some DNA markers in the stool. It's the problem with it. Some insurance companies don't cover it. It's partly because it's a little bit more expensive. It's not quite as specific as the FIT test, so it does lead to a little bit to more colonoscopies because, again, important to differentiate. The colonoscopy is a one-step screening tool. You not only do the procedure, but you take care of things while you're in there. So it's therapeutic as well. Whereas any other test we refer to, whether it's the FIT test or the Cologuard, those stool tests, if they're positive, you get a colonoscopy.
All right, very good. So colonoscopies has come up a lot, obviously. A lot of people have some fears about colonoscopies, and they hear, you're always at the dinner table, usually before a meal, right? But you're out to dinner with friends and you're talking to someone who's like, oh, I had my colonoscopy last week and it was horrible. I don't think people think the colonoscopy is horrible because, frankly, most people don't remember it. I think it's the leading up to the colonoscopy that is maybe the tough part for someone. But here's your chance, Dr. Bruling. You have an audience of millions and millions watching you right now, right? Clear the air on colonoscopies, why they're not that bad, why we need to do them, and just real quick, what that process is like for folks who are getting them.
Sure. Obviously, I'm pretty biased, but I don't think they're that bad. I do say I agree with you, and I'm honest with patients. The worst part is the stuff you got to drink, what we call the bowel preparation to clean your colon out. It's not really gotten much better over the last however many years, and you still got to drink a lot of fluid and laxative to kind of clean you out. We do split it up now where you drink half, usually the night before, half the morning of the procedure, which is a little bit easier for patients. But, we're cleaning all the stool out of your colon, so you're going to be on the toilet a lot. There's no getting around that. But I think, most of the time when you're honest with people like that, most people do okay with it. And honestly, the procedure, which I think people do have some misgivings about the procedure, being put to sleep, the risk of the procedure, but it is a low risk procedure. Most people, I know here at Pacific Medical Center, we have an anesthesia team that uses propofol now. People are very comfortable. They wake up, they're not that groggy afterwards. We even changed the type of air we use. We use carbon dioxide now instead of regular air in the colonoscopy, so people don't feel as bloated afterwards. So I think the comfort level for people is much better than it used to be for the procedure. And like I said, it's low risk, unless we're taking out a really big precancerous polyp, but then that's more reason that we do the procedure. It's good that we did it. But yeah, the bowel preparation is by far and away for most people the worst part. Yeah.
Great. Now, what can people expect after the colonoscopy? So I drink the stuff, I have the colonoscopy, it goes fine, I'm super surprised. All right, it's great. And then now it's time for me to start eating and drinking again. What can people expect, not only how they feel in the first day or two afterwards, but then what type of follow-up should they be doing?
Yeah, so usually we will, talk to them afterwards, especially if you found anything significant. If we remove some polyps, we'll tell them about that, or if we found anything else. And usually that takes a few days for the results to come back. We send that tissue off to our pathologist. They let us know are those polyps precancerous. And then we tell them at that point, whether it's usually several days later, when to come back for their next colonoscopy. And then in regards to, how they're going to feel, again, usually people wake up fairly quickly from the sedation we use nowadays, or at least here at PacMed. With the propofol, but they might be a little bit groggy, I should say, for an hour or two. And we tell them just take that day off. Don't do any driving. Don't do anything, high risk. But by the next day, they're feeling back to normal. And people usually, eat soon after. We even often give them something to drink and a snack after the procedure. So people are, that's one thing people always mention to me is they're kind of eager to eat something because they've been in some ways fasting for about 24 hours because you're on a liquid diet the day before the procedure as well.
Mm-hmm. Yeah, very good. All right, so we've gotten to, let's say I'm 45, I'm average risk, I'm going to get this colonoscopy. Dr. Bruling told me it's not too bad. Drinking this stuff isn't horrible. The procedure's not bad. We use propofol, all of those things. It's awesome. But how do and let's say, great, I have an awesome colonoscopy. You didn't find anything. There's nothing there, nothing cancerous, nothing precancerous, no polyps, nothing. How do I continue to prevent it? Like, is colon cancer fully preventable? What are the things I need to be doing to make sure, I don't want to get this?
Yeah, that's a great question. So one is to continue to get your screening, whether that's the stool testing or the colonoscopy. And, obviously if we don't find anything, it's every 10 years. So it's not that bad. In the interim, there are a number of things people can do in their lives. You know, smoking, tobacco obviously increases risk of almost any cancer, but colon cancer as well. You know, obesity can increase the risk. There are certain, you know, dietary things that might increase risk. You know, red meats, processed meats. Some of that evidence is not quite clear, but in general, it's definitely kind of lowering those things might help the risk. And that's pretty much it. And then, of course, you know, like I said, with the obesity, is just regular exercise and trying to lose weight.
Excellent. Very good. We have a couple of questions here. We've just got about 5 minutes left, and I wanted to get to some of these questions from the audience, which are awesome. These are perfect. Okay. This is kind of going back to where I was at before. My dad had colon cancer at age 50. This is from the audience.
Mm-hmm.
I've had colonoscopy since age 30. Are my children at the same risk as I am?
Yeah. No. As long as, so for instance, in this case, the listener who put the question in, so as long as they're getting the regular colonoscopies and nothing, you know, significant is being found, that means their children technically are kind of back to average risk. At least that's how we treat it with our guidelines. You know, none of these stuff is perfect, but that's how we treat the risk. Yeah.
Absolutely. And another sort of risk question, Dr. Bruling.
Mm-hmm.
We have a patient or someone watching in the audience here who has no family history due to being adopted. So are there different recommendations for that person, or should we just go with the standard guidelines?
Yeah, another good question. We go with the standard guidelines because, you know, we have to assume, and this goes for people not only adopted, but people that don't know they're, you know, are estranged from their parents or don't know, you know, what happened. We have to assume their average risk because the vast majority of people in the U.S. are average risk. And, you know, again, we'd be screening people a lot sooner, and it's a lot of resources for probably little benefit in most of these people because the vast majority of people would be average risk. Yeah. Average risk,
sure. Yeah. So, all right. So we're kind of walking through the entire process here. So let's say, all right, I've gotten my colonoscopy. Dr. Bruling did great. I drank all my stuff. Afterwards, I'm feeling fine. But on the follow-up, you think you found something. Maybe it's even cancerous, unfortunately. Yeah. What are the next steps that we're taking if that's something that you find in a colonoscopy?
Yeah. So in general, you know, if we find colon cancer, you know, this is one of the benefits, by the way, of doing this testing is because usually when we find it, it's early, hopefully, before people have symptoms and before it's spread. So the first step is to see how, you know, is to really what we call stage the cancer. So how advanced is it? Is it, you know, confined to that area in the colon? Has it spread elsewhere in the body? Usually that's with imaging, so like a CT scan or PET scan. And then once we get that, we have you meet, you know, an oncologist, so a cancer doctor, as well as a surgeon to talk about, you know, what are the next steps. And it depends on how advanced it is, whether, you know, do you get surgery alone versus having some chemotherapy. Usually those are the two mainstays of therapy, depending on the stage of the cancer. And, you know, surgery really is the only way to cure colon cancer, along plus or minus with chemotherapy.
Very good. Okay. So essentially sort of standard next steps from a diagnosis of most cancers, at least early on with those, which is great to know. We have just a couple of minutes left. So folks, if you're watching and you have some questions, here's your chance. Like you get a free consultation with a gastroenterologist, one of the best. He's doing a great job. So if you have other questions, drop them in there. We'll get to them. Risk factors. So are there any sort of groups of folks other than people who have a first degree, so parents, siblings, or their children have had colorectal cancer? Are there any other groups that may be a little bit of higher risk, at least backed by the literature, if you will, that might play a role in them getting earlier screening than others?
Sure. So the screening's the same for all, you know, races, genders. But that being said, African Americans, at least in the U.S., African Americans definitely are the minority that seem to have the highest rates of colon cancer. Now, it used to be before these new guidelines were published, African Americans were actually recommended to get a colonoscopy at 45 already. It's just that the updated guidelines kind of moved it down to 45 for everyone. So they were already kind of deemed a higher risk group. Part of that is because of the higher rates, but also some of that is just access to healthcare and getting caught late. But that's kind of the group that we need to do a better job with here, at least in our country. Getting them, numerous things are probably leading to that, but including access to healthcare and stuff like that.
Excellent. Very good. We have had lots of conversations here on these lives about, social, economic, and racial disparities in our healthcare system. So this is another one of those places where it pops up in colorectal cancer, for sure. All right, Dr. Bruling, this is it. You have the floor for 30 seconds. This is your chance. The whole world's watching. If there's anything that we forgot or we didn't get to, or you want to say to everyone watching about your specialty, the world that you live in, and of course, keeping everybody safe from colon cancer, now's your chance. Ready? Go.
I think I would summarize by saying there are not many cancers or serious diseases that are possibly preventable. And colon cancer is one of them. And while the colonoscopy, the stool testing I've talked about is not perfect, it definitely greatly reduces the chance that you will not only get colon cancer, but if you get it, you will not die from it. So I can't stress it enough that when it's your time to get this screening done, reach out to your doctor, talk about what the options are. You can see someone like me as well, just to talk about it, and just be proactive. And on top of that, if you have symptoms and you're younger, talk to your doctor. You don't have to wait if you're, having any symptoms that we talked about that are concerning.
Excellent. Everyone, I'm letting you in on a little secret. This was Dr. Bruling's first time with us, and he did great. You did awesome, Dr. Bruling. This was really great, and I really do appreciate it. Colorectal Cancer Awareness Month. A lot of folks have a lot of questions, especially because the guidelines changed. We really appreciate your time. Thank you so much for joining us today. This was awesome. And for everyone who gave us some questions, we really appreciate those. Remember, if you're looking for medical advice and where to go to get treatment, obviously we want you to visit providence.org, and be sure to follow Providence on social media at Providence on Twitter, and under Providence Health System on Instagram, Facebook, and LinkedIn. Of course, one last reminder, the information provided during this event was for educational purposes only. Got it? If you have any questions regarding medical conditions or treatment plans, please consult your physician or primary care provider. We really appreciate y'all watching this afternoon. Be on the lookout for our other lives and other really awesome topics coming your way very soon. Have a great afternoon.